Hello students, welcome to this session. In this session, we will talk about bilirubin metabolism as well as the pathological process of liver where this bilirubin metabolism is abnormal and that leads to cholestatic disorders. We will go to our first case scenario. Now I will show you 3 consecutive case scenarios and then we will go to our discussion. Okay, so here comes a 3-year female child. Now this is a pediatric patient having growth retardation and presented with yellowish discoloration of sclera with nausea and vomiting. On evaluation, she had mild anemia, mild hepato and splenomegaly. She gave history of fever 2 weeks ago which had now subsided. So I hope you have understood what is happening in the patient. So let's analyze it again. So she is a 3-year pediatric patient. She had fever 2 weeks ago. So we will go from the back. Fever 2 weeks ago. In addition to that, she has growth retardation. Okay. Now growth retardation indicates that she is having something systemic as well as something chronic that is happening for a long time, and that's why she has a growth retardation. Now what happens? She had fever, and now what happens is yellowish discoloration. Now this yellowish discoloration is called as jaundice. Okay, she has jaundice, and then on evaluation she has anemia, she has hepatomegaly as well as she has splenomegaly. Okay, now how do we explain all this? Now if you think, for starting from growth retardation, she has something chronic, and that chronic she has now anemia. So we know that certain anemias like hemolytic anemias, especially your thalassemia, can present with growth retardation as well as they can lead to hepatomegaly as well as splenomegaly. Okay, so most likely she is having a hemolytic anemia, and this hemolytic anemia was aggravated by the fever, or she gave history of fever 2 weeks ago. So she has hemolytic anemia which is going on, and then on top of it she has fever, and that fever could be because of some infection. So infection again exaggerates, or you can say aggravates the hemolytic anemia. So now she has more lysis that will lead to jaundice or the yellowish discoloration of her sclera, and that is why she is also having this nausea and vomiting, which is because of hyperbilirubinemia. Okay, so are you able to understand? So now if we go to our first question, that is what is the clinico-pathological diagnosis, then it is most likely a hemolytic anemia. So she has jaundice. This is the clinical manifestation. Again, please remember that jaundice is not a disease. Jaundice is just a manifestation, and that will be very clear when we will discuss the subsequent 2 case scenarios also. So she has jaundice, and this jaundice could possibly be because of a chronic hemolytic anemia likely to be thalassemia, or it can be also sickle cell anemia. But in sickle cell anemia, we do not get splenomegaly because there is autosplenectomy. So here you are left with only one choice, that is thalassemia. Okay, so you see the patient has jaundice because of hemolytic anemia, and the liver is overloaded with bilirubin which the liver cannot metabolize. Coming to the second question, how would you evaluate such a case? Now we will be discussing that throughout this session, how to evaluate people with cholestatic disorders, because cholestatic disorders can range from child to adult to elderly. Okay, and I will be giving you case scenarios in each category. Now we have discussed the child, then we will go to the adult. Okay, and here describe in detail the pathological findings that we will be discussing in our session. Now this is the second case scenario. Here comes a young adult or a 19-year-old female who presented with yellowish discoloration. Again, yes, so yellowish discoloration of sclera means she is having jaundice. Okay, of sclera and nausea and vomiting, and that is because of the increased bilirubin. Again, the history is similar. All this is for 1 week. On evaluation, she has mild tender hepatomegaly and she gave history of travel to a camp followed by fever 2 weeks ago. So I hope you have understood what she is suffering from, but let's analyze it again. So she is a 19-year female. She has gone to a camp 2 weeks back, and after coming from the camp she has fever. Okay, and when the fever subsides, she starts to develop yellowish discoloration, or you can say she has jaundice. Okay, she has jaundice. So if you think the history of travel, is it important here? Yes, history of travel to the camp is important because hepatitis is an infection that especially hepatitis A is an infection that is acquired from travel. So whenever there is a jaundice, this travel history is very important. And in the acute phase of this hepatitis, this will lead to fever, and later on that will lead to hepatocytic damage, and then there will be manifestation of jaundice. So if you analyze this case, this lady had gone to a camp from where she has acquired this hepatitis A. Hepatitis A causes liver injury, and this liver injury causes hyperbilirubinemia. Okay, so there, because it was of overloading, here hyperbilirubinemia is because of liver injury. In the first case, liver was normal, but the bilirubin load was more. Here the liver is abnormal because of the hepatocytic injury, but bilirubin level is normal. I mean to say, the bilirubin that is presented to the liver is of normal amount, so the liver is able to metabolize, but because of injury it is not able to metabolize. So when we go to our first question, that is clinico-pathological diagnosis, here the answer is most likely she has jaundice, and most likely etiology would be because of hepatitis. And if you think of hepatitis can be A, B, C, and D and E are also there, but we will be concentrating on A, B, C, which are more common, and if you know, B and C are acquired through intravenous route or they are parenteral transmission. Okay, and this hepatitis A is through oro-fecal transmission. So this hepatitis A can be transmitted through contaminated water, and this lady possibly would have acquired this hepatitis through contaminated water in the camp. Coming to the second question, how do you evaluate the case? Again, the same thing we will discuss in our session. And third, describe the detail of pathological finding in different samples, and different samples mean here your blood, what will be the peripheral blood picture, as well as what will be the finding in serum, what will be the finding in radiology, as well as what will be the finding in the biopsy or tissue diagnosis. Okay, so these are the different samples, and you have to write in detail the pathological finding in all these different type of samples. With that, we will go to our third case scenario. Now here comes a elderly or 59-year-old male who presented again with yellowish discoloration. So by now it should have been very clear to you that yellowish discoloration or jaundice is not a disease, it is just a clinical manifestation. Now he has severe itching in addition to nausea and vomiting, and again the symptoms are for 1 week. On evaluation, he had a near normal size liver and was distended gallbladder and multiple gallstones. The CBD was also dilated on ultrasonography, and there was no history of fever, but he had a habituation to regular smoking as well as alcohol. So he is a 59-year-old male who is a smoker as well as an alcoholic. So alcoholism and smoking can cause pancreatitis. Alcoholism and smoking can also predispose to other neoplastic conditions like pancreatic carcinoma. So pancreatitis can be there, as well as pancreatic carcinoma can also be there. Okay, so that is the history, or that is the important information that we get from his habitual history of information of alcohol and smoking. Now his liver size was normal, so normal liver size, but his gallbladder was distended, okay, and showed multiple gallstones. So multiple stones were there and CBD was dilated. What does that tell you? That there is an obstruction somewhere happening in the biliary tract, or you can say obstruction in the pancreatico-biliary channel. Okay, so there is an obstruction somewhere which is causing the dilatation of CBD, and the obstruction most commonly encountered are because of malignancy, that is carcinoma pancreatic head. Okay, carcinoma pancreas, that too in the head, and the second is gallstone obstruction. Now this patient has CBD stones, so there is a possibility that this stone would have gone into the CBD and it would have caused obstruction, or possible that because he is a smoker and alcoholic, he would be having chronic pancreatitis, or he would be having a carcinoma pancreas, which can also cause obstruction. So here again, how we will approach the case, because he has history of jaundice, so he has a liver, or you can say pancreaticobiliary abnormality. Now we have to see whether it is conjugated or it is unconjugated hyperbilirubinemia. Okay, so here the bilirubin amount presented to liver is normal. Here the liver is functioning normally, but because there is a obstruction which is after the metabolism or secretion, that is called as post hepatic jaundice.